Hi everyone. Today we are going to explore one of the most exciting advances in modern dentistry, dental implants. They are not just metal screws placed in bone, they are a reliable and long-lasting solution for replacing missing teeth, restoring both function and aesthetics. So in this session, we'll understand what dental implants are, how they work, the steps involved in the procedure, and why they have become the gold standard in tooth replacement. So by the end, you will see how implants can help patients regain their smile, confidence and quality of life. So this is Dr. Sugirta, Reader, Department of Periodontics. So terminology, dental implant. A dental implant is a prosthetic device made of alloplastic material implanted into the oral tissue beneath the mucosal or an periosteal layer or within the bone to provide retention and support for a fixed or removable dental processes. So a dental implant has three main parts. First, the fixture. So this is a screw-like part placed inside the jaw bone. It's usually made up of titanium and acts as an artificial tooth root. Second, the abutment. So this connects the fixture to the visible tooth. So think of it like a smaller connector or a support. Finally, the processes. So this is a crown, bridge or a denture that sits on the top, mimicking the natural tooth in shape and function. So together these three components work as a single unit to restore chewing ability and appearance. Osseointegration. So an apparent direct attachment or connection of osseous tissue to an inert alloplastic material without intervening the connective tissue. Osseoconduction. The graft material acts as a passive matrix like a trellis or a scaffolding for a new bone to cover. So this is how a natural tooth attaches to the bone, right? So this is a natural tooth crown. So this is the gum tissue, gingival tissue. These are the fibers holding the gums to the tooth, and these are the fibers holding the tooth to the bone. That is periodontal ligament also present. How an implant attaches to the bone. So this is an artificial tooth crown. So this is the implant abutment, and this is the gum tissue, and this is a screw type implant. This is the bone. So note that the bone attaches directly to the implant. This is called as osseointegration. Dental implant system. Dental implant components that are designed to mate together. It consists of necessary parts and instruments to complete the implant placement and abutment components. So the science of osseointegration. In 1952, Dr. Ingvar Brainmark did extensive experimental studies on the microscopic circulation of bone marrow healing in rabbit. He found that hollow titanium screw was irretrievable and he termed it as osseointegrated. Osseointegration, earlier called as bone fusing or ankylosis, was defined by Brainmark as a direct contact of the living bone with the surface of the implant at the light microscopic level of magnification. So what are the rationale for dental implants? Aging population living longer, consequences of an FPD, fixed processes failure, anatomical consequences of edentulism, poor performance of a removable processes, psychological aspects of tooth loss, predictable long-term results of implant-supported processes, and increased public awareness. So these are the merits over FPD. Like, what are the reasons for the failure of FPD? It might be because of fracture of an endodontically treated abutment tooth. A periodontal health of abutment tooth is compromised, leading to an additional tooth loss, caries and endodontic failure, bone loss. So what are the advantages of a single tooth implant over an FPD? High success rate above 97% for 10 years. Decreased risk of caries and endodontic problems of adjacent teeth. Improved aesthetics of adjacent teeth. Improved maintenance of bone and edentulous site. What are the merits over removable processes? Removable dentures it results in accelerate the bone loss, poorly fitting processes, greater bone loss, requires relining every 5 years, no proprioception, abutment loss, poor masticatory performance and bulkier processes. But in an implant supported denture, there is less bone loss. It regains the proprioception. There is no abutment loss. It improves the masticatory performance. It reduces the size of processes. It improves the retention and stability. What are the uses of implants? An individual tooth replacement as an abutment for an FPD with or without splinting to natural teeth abutments to construct either fixed, fully bone anchored, complete dentures or removable complete dentures, single complete denture as anchor in orthodontics to retain maxillofacial processes. Indications. Poor retention of dentures due to anatomical factors, poor oral muscular coordination, low tolerance of mucosal tissues, parafunctional habits, active or hyperactive gag reflex, psychological inability to wear conventional removable dentures, unfavorable number and location of natural tooth abutments, single tooth loss to avoid preparation of sound teeth while constructing an FPD, long span FPD. Contraindications: absolute drug abuse, pregnancy, bleeding disorder, psychiatric disorder and severe alcoholism. Relatively cancer, controlled hypertension, controlled diabetes, periodontal disease and smoking habits. Classification. Depending upon the anatomical site, it is classified as subperiosteal, transosteal, endoosteal. So an endoosteal implant is an alloplastic material which is surgically inserted into a residual bony ridge primarily as a prosthodontic foundation. In case of a plate or blade form, root form or pin form. Depending on the reactivity with bone, it is classified as bioactive and bioinert. Depending on the anatomical site, so this is a subperiosteal implant. So the gum tissue covers the implant framework. See, posts remain above the gum tissue as anchors for replacement teeth. So this is a metal framework which lies on top of the jawbone. So this is the endoosseous implant. Lower jawbone mandible. So the implants are placed inside the jawbone. So that is endoosseous. See, here the gum tissues covers the post. The metal plate will join the post together. So this is transosteal implant. Depending on the implant abutment interface, external hex implant, that is, the implant is connected to the abutment by coupling which is external about 2 mm superior to the coronal surface of the implant. Internal hexes, the abutment is internal to the coronal surface of the implant body. So this is the internal connection. This is the external connection. Depending on the design, cylindrical shaped press fit type, that is, it uses a friction between the implant surface and the bone. Screw shaped or threaded form which uses a thread to establish primary stabilization of the implant, allowing the process of osseointegration to occur without mobilization. So tapered screw shape is also present. Clinical implant component. So an implant body. So this is the implant body, sealing screw or a cover screw. This is placed in the implant during the healing phase following stage 1 surgery. So it prevents the ingrowth of soft tissue within the implant body. Healing screw. So it is a dome shaped screw that is placed after the stage 2 surgery done before prosthetic placement. It allows for the adaptation of the surrounding mucosa around the implant. Abutment. So abutment, it is that component of the implant system that screws directly into the implant and serves to support or retain any fixed or removable dental processes. Impression post. So this facilitates the transfer of intraoral location of the fixture or the abutment to a similar position in the lab cast. Laboratory analog, it is a component that is machined to exactly represent either the implant or the abutment in the lab cast. Pre-surgical implant guide. So this guides for proper angulation and placement of implant. What are the preoperative considerations? Patient selection. Treatment planning for success. A well-prepared treatment plan is critical for the success of the implant. So in general examination, we need to examine the general health of the patient, patient psychology and motivation, patient's age and etiology of edentulism. In extraoral examination, smile line should be considered at the first appointment. So in the intraoral examination, we have to see the jaw opening, oral hygiene, interarch relation, presence of any pathology. Radiographic examination. So pre-prosthetic imaging objectives is Objectives are to identify the disease, to determine the bone quality, bone quantity, determine the implant position and determine the implant orientation. So what are the imaging modalities that we can use are the periapical radiography, panoramic radiography, cephalometric radiography, computer tomography, CBCT, interactive CT scan. So for measuring the density of the available bone, Mish in the year 1988 gave a classification in which he says D1 is a dense cortical bone which is mostly seen in anterior mandible, D2 a thick dense to porous cortical bone on the crest and coarse trabecular bone within, it is anterior maxilla, and D3 a thin porous cortical bone on the crest and fine trabecular bone within, seen in anterior maxilla and posterior mandible, and D4 a fine trabecular bone that is posterior maxilla. Bone density assessed by radiographic technique by CT scan and also by tactile sensation by drilling through bone. So this is D1, D2, D3 and D4. What are the anatomical limitations of implant placement? So the minimal distance between an implant and an indicated structure. Okay. So the minimal distance between an implant and a buccal plate is 1 mm. Implant and a lingual plate is 1. Implant and a maxillary sinus is 1. An inter-implant distance is 3 mm between the outer edge of the implants. From the inferior alveolar canal, it should be 2 mm from the superior aspect of the canal. And inter-arch distance, it should be 7 mm. What are the steps in implant placement? Step 1. Create a full thickness crestal incision. Select the final implant location with the pre-surgical prosthetic guide so the site can be marked with the round burr. Step 2. Use the pilot drill to appropriate the depth, 700 to 1000 rpm with copious irrigation. Step 3. A parallel plane is used to determine the appropriate alignment with the adjacent teeth, opposing occlusion or other implant. A radiographic image is recommended. Step 4. When the final depth is reached with the pilot drill, the site is expanded with appropriately sized implant burr at drill speed of 1000 rpm with irrigation. Irrigation is done to remove the bone chip or residue. Now the site is checked with an appropriate trial fit gauge. Shoulder of the cone-shaped position of the gauge should be flushed or just below the crestal bone. Step 6. Implant is aseptically delivered directly to the site using the delivery tooth. Implant is pressed into the prepared site with manual pressure and delivery tooth disconnected using gentle rocking motion. Wrench torque 10 to 45 Newton centimeter. Step 7. Cover screw is placed over the implant to prevent the gingival growth into the implant and flap margins are repositioned and sutured. So this is a step 1. A hole is drilled for the implant, a cover screw is put in and left till the bone fuses and is ready for the implant. See, the cover screw is removed in readiness for the next stage. Now the abutment is attached to the implant. The final stage where the crown, the prosthetic tooth is attached. Brain marks protocol. Conventional loading. The first stage surgery, the patient is made to wait for 6 months for osseointegration. Healing period is 12 to 16 weeks. Impression for loading, 7 to 17 days are required for the formation of gingival cuff around the future abutment. Immediate implant placement. So this occurs at the time of extraction. Advantages are reduction in the healing time. Healing occurs similar as in case of extraction, which enhances the bone to implant contact. Disadvantage is that need for subsequent mucogingival surgery to correct tissues moved by a repositioned flap. Use of bone graft material to fill the socket. Increased chance of infection and implant rejection. So implant placed. So we have achieved the primary stability. What next? Corresponding restoration as full centric occlusion and maximum intercuspation and placed with 48 hours post-surgery. Immediate occlusal loading. The corresponding restoration is not in functional occlusion. Immediate non-occlusion loading. Adequate primary stability is achieved. Corresponding restoration placed under occlusal load and prosthetic functions within 2 months. Early loading. Delayed implant placement is performed 2 months after extraction. So advantages are it shares same as immediate implant placement, allows soft tissue healing, more osteogenesis adjacent to implant, no mucogingival flap advancement to correct mucogingival discrepancies. Limitations are